prevention of dental caries. Following this training, you will understand the healthcare provider's role in preventive dental care for children, the epidemiology of dental caries in high-risk populations, the cost of untreated dental infections to the healthcare system, the components of childhood caries prevention, the basic clinic process for childhood caries prevention, fluoride varnish technique, and fluoride varnish aftercare. Why are we asking medical clinics to help fight dental caries? Many children who live in low socioeconomic status are high risk and have limited access to dental care. This has resulted in a public health crisis. We need help from the primary care clinics to stop this public health crisis. What is the most common chronic disease of childhood? Dental caries. Caries is the most common chronic disease of childhood, more common than asthma, hay fever, and childhood diabetes. Dental caries has reached silent epidemic proportions in high-risk populations. Here are some facts about dental caries. Half of caries are untreated in high-risk children due to the lack of access to dental care. 80% of the disease in both primary and permanent teeth is found in 30% of the population. Populations at higher risk include Hispanic, American Indian, Southeast Asian, African, and African American, as well as families that are within or above the federal poverty level. About 1/3 of all 3-year-olds have already had tooth decay, and 1/4 of all children entering kindergarten have had at least one cavity. Cavities can be completely prevented if good oral care is practiced daily. When medical providers get involved with prevention of dental caries, more children can be cavity-free. Caries is the process that leads to a hole in the enamel of the tooth, and a hole is a cavity. Caries is caused by the bacteria Streptococcus aureus, so theoretically cavities can be prevented. What actually causes dental caries? Here is a pictorial description of the caries process. Sugar from food or liquids we consume mixes with bacteria that is present in our mouths. An acid is produced which damages the enamel of a healthy tooth and causes decay. Until recently, physicians were not taught about teeth because dentists saw all dental concerns. Today, more children do not have access to dental care, so prevention becomes more important. Childhood caries prevention should be provided by primary care medical providers and clinic staff to provide more access to preventive oral care for all children. Childhood caries prevention should be considered as much a form of primary prevention as are immunizations. In the next few slides, you will see what dental caries costs our communities and children. We will cover mortality, morbidity, social costs, and healthcare costs. There is a slight chance of mortality. Death from caries is rare, but it does happen. For example, Diamante Driver, a 12-year-old in Maryland, and a 6-year-old boy in Mississippi both died of systemic infection caused by an infected tooth. Neither had access to dental care. There is greater incidence of morbidity. Children have difficulty chewing nutritious food and often do not get the nutrition they need. They also have trouble pronouncing words that require front teeth to speak clearly. They often do not sleep well and suffer unnecessarily from pain and infection due to abscessed teeth. Social costs of dental caries involve poor school performance and school absenteeism. Parents or caregivers miss work when children are ill. Children with poor dentition prefer not to interact with other children or adults and hardly ever smile. Good oral care gives children a better opportunity to succeed. When children with pain and infection from dental caries do not have a dentist, they often go to the emergency room. The emergency room becomes the clinic of last resort and can be very expensive. The care is incomplete because the ER physician cannot treat the tooth, just the symptoms. When a child is under the age of 5 and needs extensive dental treatment, they often need the dental treatment performed in ambulatory surgery. There is increased risk due to anesthesia and added expense involved with the surgical procedure. The steps the clinic should follow for childhood caries prevention are outlined in the next slides. Conduct a gross oral evaluation. Do a short risk assessment asking parents about a dental home, dental insurance coverage, and current oral health habits. Provide anticipatory guidance so caregivers understand their role in prevention. Apply fluoride varnish 4 times a year or every 3 months, starting with the eruption of the first tooth or age 1 at the latest. And advise caregivers to find comprehensive dental care. Primary care medical providers cannot diagnose dental disease, but they can identify abnormalities. Providers should document in the chart what state the teeth are in. Here are normal oral structures, nice white teeth and good spacing and nice pink gums. Here you see white spots where the tooth meets the gums of the maxillary central and lateral incisors. This is the first sign of the caries process. At this point, fluoride will stop the caries process if good oral care is also adopted. As the decay process advances, brown spots will be seen. This is the point in the caries process when dental treatment is necessary. Fluoride varnish on these teeth will strengthen the enamel and prevent the rest of the tooth from decaying. Here are examples of advanced or severe decay involving dissolution of the outer enamel surface. A referral to a dentist is needed for urgent treatment. A dental risk assessment is completed to identify risk factors for caries and to evaluate the oral care habits of the child and caregiver. Providers or clinic staff can ask caregivers these or similar questions, and any box checked indicates the child is high risk for caries. Make sure to cover these topics when you provide anticipatory guidance. For example, your dental risk assessment questionnaire can include questions like the following. Child has no insurance for dental care. Child does not have a dental home. Child uses a bottle at night. Child's teeth are not brushed twice per day with fluoridated toothpaste and parental assistance. The risk assessment tool used here can be found on the Minnesota Oral Health Project's webpage. Providers are encouraged to edit the checklist as needed without copyright infringement. Several topics should be covered as part of anticipatory guidance. Anticipatory guidance can be taught to the caregivers while you are doing an evaluation or while you are applying fluoride varnish. Here are the 4 primary topics. Avoid sugary foods and beverages. Be fluoride smart. Have a dental home, and brush teeth twice a day for 2 minutes each time. Children should have sugary foods and beverages only at meal times and not throughout the day and night. Bottles or sippy cups with a sugary beverage are particularly harmful to teeth because the teeth are constantly bathed in sugar. Caregivers should use milk in bottles and sippy cups at meal times only and offer water between meals. Sodas and juice, even diluted juice, add sugar and acid to teeth and should be avoided completely. A sugary beverage at bedtime or nap time can be extremely damaging for teeth. Bottle mouth is a condition of severe tooth decay caused by bathing the teeth in sugar from a bottle at night. Caregivers should avoid putting their baby to bed with a bottle, but if it cannot be avoided, the bottle should contain only water. Fluoride is important for healthy teeth and works in various ways to prevent dental problems. In our caregiver materials, we refer to fluoride as a magic shield to teach parents in a relatable way. Considering the huge benefits of fluoride, in a way it is magical. Fluoride is a naturally occurring mineral found in food and water. In 2005, the CDC declared the fluoridation of public drinking water to be one of the most effective public health measures of the 20th century. Caregivers should know that private well water is unlikely to contain fluoride, so it should be tested. Bottled water and some filtered water does not contain fluoride, including water marketed to parents for mixing formula. Talk to the caregiver about the primary source of water for the child and encourage them to test well water, read labels on bottled water, or check with manufacturers of filtration systems if the children do not drink fluoridated public water. A dental home is where the child visits a dentist twice a year for preventive oral health care and as many times as necessary for restorative care. If the child only sees a dentist when there is a problem, the child does not have a dental home. Many dentists do not see children who are on public health plans, and in Greater Minnesota, the access problem is even worse. There are many more general dentists than pediatric dentists in Minnesota. Local child and teen checkup programs have dental resources for caregivers. The first time the child should go to the dentist is when that first tooth comes through, or by age 1 at the latest. A dental home is important even when good oral care is practiced daily and the child receives fluoride varnish from a medical provider. Children should brush at least twice per day with fluoridated toothpaste, beginning with the eruption of the first tooth. All children should use fluoridated toothpaste. 1- and 2-year-olds should use toothpaste in the amount of a grain of rice, and 3- to 6-year-olds should use the amount of the size of a pea. Caregivers should start cleaning a child's mouth as a newborn, taking a moist cloth to wipe the gums after each feeding. This serves 2 purposes. The baby gets used to having their mouths clean, so when they have teeth, they adjust to brushing easier. It also keeps the mouth clean and healthy. When the first tooth comes in, start brushing with a soft brush with fluoridated toothpaste, an amount no bigger than a grain of rice. Wipe out the excess toothpaste with a moist cloth. Many caregivers believe that baby teeth are not important because they fall out. Healthy baby teeth lead to healthy permanent teeth and should be cared for daily. Children need to have adults brush their teeth for them until they are old enough to adequately brush all teeth. The back teeth, with all their nooks and crannies, are particularly hard to brush. Medical providers should apply fluoride varnish to all surfaces of the teeth 4 times per year, or if the child has a dental home, twice a year. Fluoride helps remineralize teeth so the enamel is stronger and prevents demineralization of teeth. Fluoride also inhibits the growth of bacteria that cause caries. Fluoride varnish comes in single-dose containers. Most brands leave an ecru or yellowish color on the teeth, but some manufacturers have a white varnish. Now let's see how you apply the fluoride varnish. This video footage was made by the Minnesota Oral Health Coalition.
The whole process takes less than a minute. Either a medical assistant, nurse, or healthcare provider can apply the varnish. You will need gloves, gauze, and the fluoride varnish single unit vial with its brush. After washing hands, put your clean gloves on, which do not need to be sterile. You can put a small amount of the varnish on top of your non-dominant gloved hand. For infants and toddlers, the knee-to-knee position is very effective. The parent or caregiver holds the child facing her with the child's knees at either side of their waist. The child's head rests on your lap, and the parent or caregiver can gently hold the child's arms. If the child cries, as many will, this will actually help open the mouth. Use the gauze to dry excessive saliva from the tooth surface before painting the varnish. It is okay if some saliva is still there, as the saliva fixes the varnish to the tooth surface. Paint all the surfaces of the teeth, both the front and back of each tooth, and be sure to paint the chewing surfaces of molars. Most providers apply the varnish in quadrants to be sure to paint all teeth that are present. In children 2 years and older, who typically have 20 teeth, start with the left upper back. Then move down to the lower left, then lower right, then upper back, and finally the front, upper, and lower teeth. Most varnish comes with a yellow tint, so you can keep track of where you've already applied it. You only need to apply a thin coat of the varnish, and you don't need to use all the varnish provided. That's it. Tell the caregiver that the child can eat and drink warm or cold liquids and soft foods right away. Avoid sticky, crunchy foods and hot liquids for 24 hours. Don't brush or floss until the next day. The slight yellow discoloration of the teeth will come off with the next tooth brushing. The child should be referred to a dental home for regular visits where varnish can be applied at each 6-month visit. If the child is high risk for caries, the medical provider can apply varnish alternating with the dental provider, as these children should receive fluoride varnish every 3 months to prevent caries.
Okay, that is how you apply fluoride varnish. One more thing about the aftercare instructions. Post-varnish instructions are available in 8 languages at crushcavities.com/clinics. All caregivers are encouraged to find a dental home for their child. If dental abnormalities are suspected, referral to a dentist is essential. Fluoride varnish is very important to prevent cavities in young children, but fluoride varnish alone cannot stop the caries process. Fluoridated water, a dental home, and daily oral health practices are equally important. All children should have sealants applied to the chewing surfaces of permanent teeth, and sealants can only be applied by dentists. Adopting childhood caries prevention is easy to implement and does not take a lot of extra time. The risk assessment can be done during the admission process with the staff asking the questions or the parents completing the form. The application of the varnish can be done at any time, but preferably before immunizations. A consent should be signed according to clinic policy. Use your electronic medical record, for example, EPIC, to alert staff for the date of the next application. Childhood caries prevention must be done at C&TC medical screening and can be done at sporadic visits or other well child assessments. There are no contraindications to fluoride varnish. Billing is done with the CPT code 99188 on the CMS 1500 billing reimbursement form. Document acceptance or refusal of varnish. The staff at the Minnesota Oral Health Project are available to help with training, implementation of childhood caries prevention, and resources for your clinic. We can also provide direct education to caregiver groups or children's classrooms. Our educational resources can be used to provide your own educational programs. Many organizations support the work of the Minnesota Oral Health Project. After today's training, you can find additional information on crushcavities.com. You can find required reading and a quiz for CEU credit. Translated resources for patient education and childhood caries prevention can be found and printed from the website. Thank you for viewing this training program. We hope it has been beneficial. Please do not hesitate to contact us with your questions.